Hello everyone, welcome to MEDICA Cardio Talks episode 24. And I'm really excited today as we are joined by two young dynamic cardiologists, Dr. Ashesh Halder and Dr. Debopriyo Mondal. Hello Dr. Mondal and Dr. Halder. And I'm even more excited because the topic of today's discussion is really very exciting. And that is on anti-obesity drugs, which has been probably the biggest medical story for last 1 or 2 years. So we are aware that by 2030, 50% of global population will slip into overweight zone. Also, we are aware that obesity is the 5th biggest cause of mortality globally. And based on the FDA approval of two molecules in last couple of years, the market value of anti-obesity treatment drugs is going to be something about $100 billion by 2030. This is what the projection is. And now, Mounjaro, Ozempic, Zepbound, and Wegovy, they are the household names in US, and these molecules are out of stock. So with this hype and pretext, let's discuss the evidence and the caution which we should be having. So Dr. Ashesh, first I turn to you. What are these two molecules which have been approved by FDA and how do they work?
Thank you, sir, for the question. Actually, these two molecules are one is semaglutide and one is tirzepatide. And if you want to know how they act, then you need to know a little bit about some physiological aspects. So there are two molecules. One is known as GLP-1, that is glucagon-like peptide 1, and another is gastric inhibitory peptide GIP, which is also renamed as glucose-dependent insulinotropic peptide. So these two molecules are actually categorized under incretins. The principal mechanism is to increase secretions of insulin from pancreatic beta cells and sometimes modify the glucagon secretion. So apart from that thing, there are several other mechanisms in respect to other organs, just like adipose tissue, in brain, in liver, several other. So principally, how the semaglutide and tirzepatide act. The semaglutide is actually GLP-1 agonist, and the tirzepatide, they act both as an agonist of GIP as well as GLP-1. So this is the principal mechanism.
So these are two molecules, semaglutide and tirzepatide. And now I turn to Dr. Debopriyo. Do they really reduce body weight, and what are the evidence, and are they safe? And do we have, because we are cardiologists, do we have CVOT trials with them?
So sir, I think today's discussion is probably a very fruitful topic, because obesity, as sir has already told, that this is going to become probably the 5th biggest killer of humankind, taking lots of lives, and not only lives but also destroying the quality of life. And most importantly, or rather fortunately, we have molecules which are coming up, let's say every 2 or 3 years. It started from 2010 when we used to have orlistat, which got an approval, and starting from orlistat we had molecules like topiramate phentermine, and then we had other molecules, and recently the two additions which have been the talk of the town. So coming to the evidence, we have trials for semaglutide, we have trials based on the CVOT outcomes as well. So coming to obesity, does it really work? Obviously all trials have shown that there is a definite weight reduction with semaglutide, which is a GLP-1 analog, and tirzepatide also, which is a combined dual GLP-1 GIP-1 analog. There is a definite role in weight loss to the tune of around 5 to 6 kgs, which is not there with any other anti-obesity drugs. And the potential side effects of GLP-1, what we discussed, is the GI side effects. So GI side effects has led to a discontinuation amongst a few patients, but then they are well tolerated by, almost all, apart from a few. And the side effects will range from something like dyspepsia, something from stomach irritation, or GI intolerance.
So how much is the percentage of patients who are really intolerant, so they have to give up these medicines in the trials?
So probably in all the trials what we have seen this far, there is a number which is ranging from around 15 to 16%, and probably what sir will be discussing is this number was probably higher, and then with the recent generation this percentage has come down.
Right? So recent trials have shown around 14 to 15%. That is acceptable, I feel. Now let me turn to some of the important trials which have come up recent past, like SELECT trial. So Ashesh, can you just tell us something about SELECT trial? And
so in SELECT trial, the semaglutide was tried in a specific patient population. We have seen that was used and already got an FDA approval for the treatment of obesity. But in SELECT trial, the patients who were selected who had cardiovascular disease, already established cardiovascular disease, and who are obese, who have BMI of more than 27, and along with that the patient don't have diabetes. So they were divided into two groups in 1:1 fashion. One group was receiving injectable semaglutide 2.5 milligram subcutaneously once in a week and compared with the placebo. So at the patient population was used, around 17,500 patient population was there. So after the end of 40 months they saw that those patients receiving semaglutide, they had an excellent outcome in respect to cardiovascular outcome. So they assessed cardiovascular death and non-fatal MI and stroke, and it was significantly lesser those patients receiving semaglutide, and it was around 18 to 20% reduction in that patient population.
So SELECT trial showed us it's not only diabetic patients. Any patient who is obese, overweight,
yes,
and who is having cardiovascular disease, coronary artery disease, they are going to benefit with this drug, and that is a significant, difference.
Significant difference.
Yeah, and coming to from cardiovascular to renal outcomes, we had a FLOW trial which was ongoing. So, Debopriyo, kindly let us know about the FLOW trial and where exactly it is, at this moment.
Sir, actually the FLOW trial was aimed for the renal population, wherein they were subdivided into groups based on the eGFR as well as the urinary albumin creatinine ratio. So they were subdivided into, let's say, eGFR of 60 to 75 and then subsequently coming down. And what was seen was there was a significant trend towards benefit in patients who had less of eGFR, or simplistically speaking, in patients with CKD and albuminuria, there was a trend towards significant benefit, so much to the extent that the trial was supposed to end by this year December, but then with the huge benefits seen, the trial was prematurely stopped because of the huge benefit of this drug.
Yeah, I think it's really something which is very surprising, Yes. So DSMB board prematurely stopped the trial because of the overwhelming benefits, and from cardiovascular to renal and some evidence on liver. It's not something surprising to see the jump in the use of these molecules. So it is not 1, 2, 3, 4 fold or 100-fold. It is 4,000 fold increase in the sales of anti-obesity molecules in drugs in US, and that is why it is out of stock. And companies are struggling to maintain the demand, supply as per the demand. Dr. Ashesh, how do you feel? Is this going to replicate same way in Indian population? The Indian doctors will be having.
So that is a huge barrier that it is difficult to maintain that thing in the Indian market also. So insurance coverage is extremely important regarding this. When you are procuring a drug for the patients, that should be insured properly. Yes. Otherwise, it is difficult to maintain in India.
This is very costly drug, and we have come to know that in US, even those patients who are not insured and Medicare is not providing reimbursement, even then they are taking this molecule. So a huge promise these molecules are holding, and it's also very happy to see 36 new molecules are under investigation. 6 are under the regulatory board approval methodology. So coming days are probably days of anti-obesity treatment, and that's what the business people, they are equating this hype of and surge of market value of these two companies, something like AI. So AI on one wing, and second is anti-obesity molecule on other wing. So it's a healthcare is really going to have a huge different way of looking at in coming days. So with this, I think we are hopeful that in India the problem of obesity will be countered by these molecules, provided we keep on getting these positive results. So before finishing up this MEDICA Cardio Talk 24 episode, I would just like to have a small discussion on the antiplatelet therapy. We are also getting some newer insights. Like we all cardiologists, when we get a patient of acute coronary syndrome, we load the patient right in the emergency or a CCU, and then take up the patient in the cath lab. So, is there any recent change in the kind of evidence and thought process or guidelines on this?
Sir, probably this talk is coming because of the recent EAC 2023 guidelines, wherein they have shown, or rather the guideline recommendations has been stepped down from class 1 to class 2B in regards to the preloading strategy. So the recent guidelines say that probably there is no added benefit of preloading the patient with ticagrelor or rather any P2Y12 inhibitors while the patient is being transferred, because it has been seen specifically in both STEMI as well as NSTEMI that if you load patients with P2Y12 inhibitors beforehand, this does not translate into better cardiovascular outcomes in the short term. Rather, it also does not correspond to better flow in terms of the revascularization part. And coming to this, that is why there has been a discussion on to what is the actual methodology which has to be followed when we are loading patients. And herein probably we should start talking more about the intravenous agents, wherein we get better results probably rather than loading with oral drugs.
Yeah. So you see a kind of a value in this, not preloading, because if you preload and if the patient comes to be a candidate of surgery, or maybe on a different note, if the patient doesn't require any intervention, do you feel this is going to benefit? And do you agree with this recent change in the guidelines?
So I agree because of two reasons. There was a potential benefit of these drugs if you pre-treat the patients. So we need to more focus on something else. What is pretreatment? Pretreatment denotes you are treating the patients with P2Y12 inhibitor before doing coronary angiogram. So before knowing the coronary artery anatomy. So that is quite important, and there was a potential benefit, but no large scale trials were there which have shown is a great benefit in respect to revascularization, as Dr. Debopriyo has said already. So yes, with regards to this specific question, there are some changes, like in patients with STEMI, we can pre-treat the patient with P2Y12 inhibitor, but that is class 2B indication.
Yeah.
With regards to STSCS, the recommendation is little bit of different. If you feel the patient will require early surgery or intervention, then pre-treatment is not required. Only you can pre-treat after knowing the coronary artery anatomy.
Yes.
If you know the patient, you can delay the procedure more than 24 hours, then you can pre-treat the patient.
Definitely. So I think wonderful. So we had a a wonderful talk and discussion on anti-obesity medicines and the newer changes in insight on preloading with P2Y2 inhibitors in acute coronary syndrome patients, and I hope it was useful for all my viewers. And with this we conclude here, and hoping to see you all in the next MEDICA Cardio Talk episode 25.